Good afternoon, everyone. My name is Mitchell De Rosario. I am the Vice President for Academic Affairs at the Graduate Student Association at the main campus. And I want to invite all of you guys to the Books and Bagels Center City version of it. We have similar events going on main campus, which you're all welcome to come to. We have a Books and Bagels and a Books After Dark, because we understand that all of you guys are grad students here, by a show of hands. So one of the things we know that grad students really like is research and talking about research and alcohol. So what we do is we have Books After Dark for all the graduate students to come in, and we have a relaxed discussion afterwards as well. That being said, thank you for coming to this event, and without much ado, I want to invite Nguyen from the Student Affairs, the Director of Student Affairs, to come and moderate the discussion.
Thanks, Mitchell. So I can sit here and moderate, yeah? Or I can. Okay. Well, I'll first thank you for coming, and thank you, GSA, for finally bringing this event to Center City. This is our first sort of Books and Bagels event here, and we're looking for other future presenters. So I hope that after today, maybe some of you will maybe send me an email and let me know that you are interested in sort of presenting. You'll see that it's a very casual, comfortable environment for you to share what projects you're working on. Our first speaker is Senem Zeytinoglu, yes. And she actually just defended her, I believe, her dissertation.
No,
proposal. Her proposal. And she will be talking a little bit about her project and her research, what she's working on.
Oh, like this? Yeah. Okay. Is it okay if I look at the audio? Okay. All right. Hello. My name is Senem. I am a doctoral student at Couple Family Therapy Program at Drexel. I am originally from Turkey, and I have moved here for my master's program. I did that in New York at Columbia, and then I worked in New York for a little bit, and then I moved here to complete my PhD. And hopefully this is my last year here, so I will be returning home to work there. But I wanted to tell you a little bit about, what my story was, what my journey was, and then some tips about, what helped me during my dissertation process. So when I first moved here, I was at Teachers College, Columbia University, and I picked that program because the focus was multiculturalism. And I was really interested in that and learning about social justice. And it proved out to be a very interesting experience. I felt like, the understanding of multiculturalism in the United States was very different from the understanding of multiculturalism that I had in my mind. So it was challenging, a little disappointing, but I learned a lot. And then I started working in a high school in the Bronx, and I was running a teen relationship abuse prevention program there. I had 4,000 students, and it was just very interesting for me, because then I learned what multiculturalism is actually, because I was working with students who were completely different from me in terms of language, in terms of socioeconomic background, in terms of race, in terms of country, in terms of religion. Everything was different. And I loved that job. And I found that, counseling psychology was very helpful, but what I struggled with was the lack of the systems framework. What that means is that I wanted to work more on the relationships rather than the person itself. Because I didn't see the problem in the person, I saw the problem in the relationships. So that is why I wanted to go for my PhD in a family therapy program, because I believed in the healing power of relationships and the systemic framework. So, and I'm not gonna lie, one of the reasons that I chose Drexel was that it was in a city, because all the other couple of family therapy programs are in the middle of cornfields. So it was not really suit well with me. I get very depressed in the suburbs. So, but I knew that they had two focuses. one was, again, social justice, and then the other one was self of the therapist. Well, my program experience at Drexel was disappointing because I didn't find the information that I was looking for. I didn't find the kind of social justice perspective that I was looking for, or the self of the therapist work that I was looking for. But it came out to be a great experience at the end because I found the person that I wanted to work with as my mentor. I found her in my program before I came to the program, but she is, she is the best thing that ever happened to me at Drexel. And if there is one thing that I can tell you, that choose your mentor very well. And it is, ultimately for me, her research interests was part of it, but for me more so it was her life and her personality. I wanted someone who is similar to my background, so I wanted someone who knows, so that's why one of the reasons that I picked her, because she is Jewish and I work very well with Jewish people because I grew up with them at home. So that was one of the reasons. I chose her because she had a family, so she knew what that meant and she knows the importance of it. So she encouraged me when I wanted to spend time with my family, when I wanted to go home, when I was feeling stressed out and using my parents as a resource. She did not see that as dependency or enmeshment, but as support. She worked very well with me because she was open to listening to me and made herself available for me. And she made herself, she supported me. I was able to call her when I needed, emotional support. She was always there for me. And I think that ultimately what mattered for me the most. And when I was choosing my dissertation topic, she did not push me to do something around her needs. She worked with me to choose whatever I wanted, and she supported me and she directed me. She gave me clues on how to get done with my dissertation in the timeline that I wanted to get done. My dissertation topic is working with couples who are raising a child with cleft lip palate, and I'm looking at, does everyone know what cleft lip palate is? Okay, cleft lip palate is like when you have a gap between your lips and in your palate, and it's a congenital condition, and you're basically born with it. And now they're able to diagnose it prenatally and postnatally. So I'm looking at the difference in couples of how they adjust to the process when the child was diagnosed in utero and when child was diagnosed at birth. It's a qualitative study, so I will be interviewing the couples and to learn about how it impacted their relationship and how they're making that process work as a couple. Because ultimately, like my clinical interest lies with couples too. So that is why it was a great match for me. And so the key thing was I was very lucky with the dissertation process because what I did was I looked for people who was doing research in my area in Philadelphia. So I got in touch with this person at Children's Hospital of Philadelphia who is the psychologist on reconstructive surgery department. And I, met with her to see if she has any ongoing research projects that I can be a part of. And she did. So she had an ongoing research. And what I did was I added on to her study doing the qualitative part, and which was very helpful because she was another person on my corner. She provides me with the sample that I need, and she really is the expert on my topic, which then gives me the opportunity to go to her with questions. I was born with cleft lip palate, so I know, I know some of the struggles, but I'm at this point, 29 years old. So the time has changed, the technology has changed, the medicine has changed. So she is able to update me on the current issues, and also, I cannot just assume that everyone has the experience that my parents have. So it's just a good check-in person for me. I defended my proposal. One thing, that I want to tell you about, some things that, you need to watch for when you're doing your proposal is that not everything depends on you. But is that, like I get stressed out because I have a timeline that I need to get done in. And I did everything right. Like, I did my proposal, I started early, I started last year in May. I submitted my proposal for IRB approval in November. But the IRB took 5 months. So like these are the things that like we need to be prepared for, it's just the things to keep in mind, because I'm the person that usually resorts back to self-blame when things don't go well, it's like, oh, what did I do to make this happen? And at that moment, my chair stepped in, and like that's what I'm talking about when I talk about emotional support, because what she said was, no, like this is politics, you need to understand the politics of research. Especially doing research in another institution other than yours, because I'm not doing research at Drexel, I'm doing it at Children's Hospital of Philadelphia. So you need to keep these things in mind in terms of like, even if you have a timeline, someone told me before that, I need to give it 6 months, it's usually gonna last 6 months more than what I expect. And I was like, well, that's not gonna happen to me. Well, I was being very arrogant. Because this is exactly what happened to me. So I intended on finishing in May, and now I'm looking at October. So, and it's just, it's just life of doing research with human subjects, especially in a department where, it's pediatrics. I am doing phenomenology as the qualitative methodology. Anyone is here familiar with it? Anyone who does research in social sciences. Okay. So qualitative research, phenomenology is basically what I'm going to be looking at is the meanings that parents attach to their experiences and the essence of their experience. So that's what I'm going to be doing, and I'm going to be interviewing 10 couples in each group and seeing the common themes in their experience. So 10 couples who was diagnosed postnatally, 10 couples who had the diagnosis in utero, and see, like if there are any differences in their adjustment process. And I think, it is important because in the sense that, have you guys ever heard of biopsychosocial approach? So we basically, when we're in medicine or in physical sciences, we look at the biological part of what's going on. We look at the MRIs, we look at the condition, we look at the treatment prognosis, but we don't really go back and consider what kind of an impact it has on the patient and the patient's family. So in terms of the psychosocial part of it, that's what I'm hoping to get from the experiences of these people. Any questions that you have?
I know you talked a little bit about sort of your personal experience, so thank you for sharing that. Was there, could you talk a little bit more about how, why it was important to you, and why is it important maybe to society to also sort of hear, your research on this
Sure.
topic?
Because see, I think, having a child with a birth defect is a trauma on the family. And I'm very interested in knowing how people cope with trauma. So, and I think my research is beneficial because there has been a huge gap in research about how couples cope with it as a couple. Everyone is looking at individual parents, but they're not looking at the relationship between the couple and how it changes by this trauma in the family. And the other thing is, no one is really looking at how the family is impacted in the long term by having a diagnosis prenatally and postnatally. Everyone is, the parents are interviewed at the time of the diagnosis, so they can talk about their feelings in terms of, a lot of the times they feel self-blame. You know, what did I do to cause my child this condition? Like, is it because, you know, I was smoking? Is it because, you know, like I didn't know I was pregnant, so I was drinking in the beginning of the pregnancy? Does it run in my family? Does it run in my side of the family or in my partner's side of the family? You know, like, so they're dealing with a lot of like questions. They're dealing with a lot of shock, grief, of like, you know, losing the image of the perfect child that they had in their minds. And they're dealing with a lot of anxiety about what's going to come next because they don't know how they can care for this child. So a lot of the parents who was diagnosed at prenatal condition, they're saying, okay, but I have time to figure out, right? Like I have, you know, they usually get diagnosed in the second trimester, so that I have a lot of time to figure it out. And what I wanted to look at was that in long term, you know, up until the child was 4 or 5, do they still feel the same way that, you know, like, oh, I knew before, so it helped me to adjust when my child was born, not only at the time of diagnosis, but once they have the child and once they raise the child up until the age of 4, how it impacted them. So, and those are the 2 gaps in the literature that no one, you know, really no one has done research about. So that's what.
I do want to have hopefully an open conversation. Yes, did you have a question?
Yeah, I was just wondering if the research you're doing, what you hope to learn from it, can it be applied to other congenital diseases?
Right. What I hope to learn from it is that how can I help couples when they, you know, like when they're adjusting to this process. That's what, like, that's ultimately my goal. And the crucial thing about that is that because my research is qualitative, it is really important that I keep the sample that I have in mind because I cannot generalize it to every other population. I can just have a glimpse of what it looks like in, you know, like this sample and what are the experiences, common experiences of these people. But for me, you know, like I really need to keep in mind that I need to replicate this research in other settings. So that's, you know, that's going to be the next step basically. But it's the, you know, that's the a little bit draining thing about research, especially qualitative research, that, you know, you can never know if like this, what you found here is going to work with other people. You just need to try out and see. Yeah.
Do you see the impact on the child, the children? Do you consider the impact on the children, the family, relationship between couples?
I can see if there's an effect on the child. Yeah. It's just that I'm not focusing on that in my, you know, dissertation. But I think, well, you know, coming from a systemic framework, I think it's impossible that if something is going on in the parent relationship, it's not going to impact the child. And actually, research shows that parenting stress, if it is high in families with, you know, coping with Palate, the child's psychosocial adjustment is also impacted. So the child is, for example, more withdrawn. So you're absolutely right on that. There's an impact.
So, in your when you're looking through literature, are there different ways of coping for different backgrounds? So I'm thinking, like, you know, is there a relationship between the background that you have and how you cope with it, maybe the level of education or where you come from, urban versus city? And then is that something that is going to show on your methodology? Is a sample size of 10 enough to, or maybe even answer that question?
No, I think, because see, the thing is, I have a sample set for me. So my sample is really predominantly white and usually, like, you know, college educated or school time. So the way that they cope with it is going to be so different from any other group. So it's not telling about, you know, how people cope in different cultures, in different settings. I know that, you know, based on my, you know, literature research, I know that people like cope very differently. There are a lot of people who use spirituality as a resource, you know, like based on the cultures that they're coming from. There are a lot of different cultures, people use extended family as a resource. In some cultures, they believe that the kid is, like this condition is caused by evil spirits, so they don't want anything to do with the child. So it's going to differ based on the sample.
Well, in that case, my second question would be, in that case, would there be a lot of stress? Because if you are already college educated, I would assume that you can pay for a preventive surgery, right? So in that case, is there going to be more, like, I mean, in terms of like a facial reconstruction or a surgery like that, in that case, do you think there's going to be a lot of stress compared to like other backgrounds that probably won't be able to afford it? Or
you know what? I think you're absolutely right in the sense that because there are kids who cannot really, there are families who cannot really pay for the surgery. This surgery is not available. Like there are 3 or 4 organizations that I know who goes to developing countries and like do the operations there so that the kids can have access to this kind of surgery. But the thing is, the other thing is, Cleft of Palate has a very long-term treatment process because it impacts, you know, dental, it impacts, you know, there's going to be an orthodontist, a dentist, a plastic surgeon, a speech therapist, an audiologist, what else am I thinking about, a psychologist, so it's and it lasts until like young adult since birth. So yes, granted that the stress will be a lot less because the opportunities are there, but we cannot just say that they're not going to be stressed at all. You know, so their experience is just going to be a different experience with probably, you know, a lot smoother. But my assumption, and let me see, I need to keep that in check too, but it's not going to be a walk in the park either.
You mentioned the cutoff age, well, not really cutoff, but you're tracking the families till age 4, the child of around age 4. And why did you select that age?
Because that's the sample that I have. So this psychologist sample, they have kids between the ages of 0 and 4. So that's why.
Okay. So
One thing that I want to say. And I think, you know, that's the one thing that I always heard from my mentors and professors when I entered the program. Like, think of your dissertation research as another research, not your whole career. So that is why, like, I really took the route that would be most suitable, like, and practical for me. So that is why, you know, like, I am invested in my topic and in my research, but I see it as not the answer to all my questions. So that is why, like, it worked well for me to have that kind of set sample.
That's a really, really great point for those of you who are considering, who are working on projects now, that this is not, you know, sort of the project that might just define your whole career, that it is just a small journey. And I love that you said that it's your journey because you will probably move on and maybe do other areas and research and maybe smaller projects and things like that.
Right. Next step for me is actually I will be working in a hospital in Turkey with craniofacial anomalies. So, like, I'm hoping that the same things that I have, like the questions that I have, I will get the answers from the people in my country and see like how they cope with it and see, you know, like if there are any differences. But that's another project for the future. You know, it's just that it's just a journey.
Yeah. Great. Well, thank you so much. I'd like to introduce Renata Carneiro. She is going to talk, she's also from the couple therapy program, and going to talk about, well, actually I can't even this is the fulfillment. Well, she'll tell you about it, because, and I have a story about that, because she's going to a conference, she's presenting something else, and then she's presenting something for us this Saturday, and there's so many different topics, I can't even keep it straight. So, thank you, Renata.
Yes, my name is Renata Carneiro. You're going to see, oops.
No.
You can switch over. Yeah, we can take a second.
It's on the desktop. Therapist attraction to their clients.
So, my name is Renata Carneiro. I'm the Couples and Family Therapy Program, the PhD program. And Senem and I are actually classmates, and we're in different process in our dissertation. I'm doing a full-time internship right now that's getting me a little bit distracted. I get really into the clinical process. I love doing clinical work and work with family and couples. And I also feel that research is very important, but I always like to look at the bridge between research and clinical practice. So I pay a lot of attention in my clinical practice and the things that I struggle the most. So the things that I struggle the most are usually the things that I want to focus on. And then attraction to me was something that I struggle with a lot of my clients. Because when we're talking about attraction, I'm not talking necessarily just about sexual attraction. We talk about attraction several different ways. There are clients that I have, families that I have are like, it's such a big family, you know, I would love to spend more time with them. Well, why do we can't just have to be therapist and client, and, you know, why couldn't we just hang out and be best friends? You know, it's hard because I spend a lot of time with people, and many times I gotta remind myself, what is my role here? You know, what am I doing here with this family, doing this work? So, but for my research particularly, I want to focus more, as Senem was saying, it's a huge project, right? So we just have to take a little piece of the pie. So I want to focus more on the sexual attraction of it, because I feel like it's one of the most strongest feelings that you can have towards a client, and I'm very curious to know how therapists handle that. And there's not a lot of information on the literature, and I felt also through my training, I did my bachelor's in psychology, I did my master's in counseling, and now doing my PhD in family therapy. There's not much conversation about, if this happened, what do you do? All we know is, ethically speaking, we're not supposed to do that. You're not supposed, not that you're not supposed to attract your client, because we're just human beings and we are going to be attracted. Especially if you have that specific setting, there's a lot of sharing, there is a lot of connection, because we connect with people, it's bound to happen. But then there's nothing to say how you navigate through that. All we know is that you're not supposed to cross the boundaries, and cross the boundaries could be so many different things, right? Including cross the boundary by having sex with a client. We all know that, we're very clear, but we don't know what to do, and sometimes that can cause anxiety. So I'm looking at sexual attraction, and I'm looking from a feminist perspective. And how many of you are familiar with the feminist approach? There's a lot of misconception about feminists, that they think that they are man-haters, right? A lot of people say that, no, I don't like feminists, they're man-haters, they hate men, blah, blah, blah. That's not true. And there's a lot of schools of feminism. Feminism is just one big umbrella, and there are several different schools within the feminist approach. And that approach that I'm looking at in my lit review is the liberational feminist. And the liberational feminists are the feminists that believes in equal rights, that believes that everybody should have the same rights, regardless of your race, of your gender, your sexual orientation, your religion, any of the social context. So that is the area that I'm kind of looking more towards to, and that's what I have done my lit review. Okay, so moving on. Moving on. So this is a little bit of an overview of my presentation. Why it's important to manage attraction to clients. One of the things that I have seen in the literature, and there was a lot of studies around late 70s and 80s, about towards the 90s, and then we found some in 2004, 2007, and then dropped. Nobody's talking about that anymore, right? And some of the studies have said that when attraction is not managed in session, there are things that happen as far as early terminations. The therapists that don't know how to handle that attraction and feel embarrassed, uncomfortable, even frustrated with that process, so they terminate the clients. So that could be an ethical problem too, to do an early and abrupt termination without an explanation or a proper transfer to your clients. And also could have a problem if you don't know how to manage your attraction, that you cross the boundary and become intimate with your clients, which is not a good thing. So I also want to talk to you a little bit about epidemiology, how often it occurs, and the intersection of attraction and mental illness. Who's at risk, a little bit about the feminist approach, what are the research gaps that I found, and some of my recommendations. So why is this important? What is the social importance of this? Well, the APA, the American Psychological Association, says that in 2004 there was 35% of complaint towards psychologists crossing the boundaries, crossing the ethical boundaries regarding attraction. So it's hard to tell exactly how many numbers happen, and it's hard to tell what exactly the boundaries that were crossed, because you have people reporting to board committees like APA for the Psychological Association, APA for the Psychiatric Association, AAMFT for the Family Therapists, for Nursing Association. You have so many different reports, and also you have in the literature a lot of surveys that were done with practitioners that have self-reported being involved with a client. And usually when you look all of those numbers together, they don't match. Usually the surveys is a very small number. The highest number you see in psychiatrists, there's about 7%, and the smallest numbers you see in psychologists. But then when you compare to the board complaints, the numbers are higher. And that could be for several reasons. When you look at the surveys sent, they're usually sent for a specific state. So if the researcher is doing a study in Pennsylvania, the survey is going to be distributed in Pennsylvania, right? Now, when you look at the APA, they're looking at national data. So that's why the numbers are hard to keep track, because nobody's systematically looking at this. Now, a lot of the national surveys that were done regarding attraction itself, and they were done in several different fields, family marriage therapy, done with psychiatrists, done with psychologists, all across mental health fields. Several researchers have pointed out that 86% of male therapists or mental health professionals say that they felt attracted to a client at least one time. And 24% of the female therapists have felt attracted to a client at one point in time. So it's interesting to look at and see there's a gender difference, that men overly report more attraction to a client than women. And that is consistent even when you look at students in training. There was one research for family therapists that they were looking at graduate students in their first year of clinical practice, and they found exactly the same number. More male students report feeling attracted to their clients than the female students. And another thing that I found here is, and we don't have a lot of information in the literature, is that 46% of the therapists say that the way they would try to resolve their attractions is to talk to their supervisor, right? Now, what happened to the rest of people, right? What happened with the other 54? What are they doing to manage their attraction? We don't know, right? And nobody had asked them. Nobody had taken that sample. Now, when you look like who is at risk, the profile that can emerge from the literature when looking at specifically national surveys that ask therapists and mental health professionals about their social demographic information and also about their attraction, they look from the client perspective. Usually the clients who become sexually involved with their therapist are young females who have an Axis 1 diagnosis. Axis 1s are the mood disorders, and usually they are victims of sexual abuse or incest when they were children. And what I found even more disturbing to me is that this is even true when the therapist is another female. So it's not only male therapists engaging with female clients. You also see that female therapists engage in sexual activities with female clients. But it's more prominent for male therapists to do that. And the therapist, the prototype who's more at risk to be involved with the clients are white males in their middle age who are usually going through a loss or a separation. okay, so what is feminism, right? What is the feminist approach in general? The big umbrella of feminist approach focus on? It focuses on power inequality in the therapeutic room. So when the feminists came about to talk about sexual attraction and also to talk about sexual intimacy with the clients, they pointed out that it cannot, there's this argument that, oh, it's okay sometimes for the therapist to fall in love with her clients. I can say, I fall in love with a lot of my clients, but I don't mean love by romantic love. I feel love by compassion, that I understand their suffering and I empathize with them. But there was some research and some authors that say that, well, you know, the therapist fell in love with this client, so it would be justifiable to become sexually involved with this client. The APA, both APAs, did not make this unethical until 1977. So before 1997, there was nothing there to say that was unethical for therapists to engage in sexual intimacy with their clients. But then the feminists came in and they said, well, it's a boost of power, because there is a power inequality in that relationship. And it doesn't matter how much time passed by, because most of the professional ethics boards right now, they will say between 2 and 5 years, you can be romantically involved with your former client. But that raises a lot of questions. Who is really your former client? Because clients come back to therapy all the time. And is there ever going to be an equal relationship? Or is it going to be that power inequality? Because as therapists, we don't share much, right? We are there for the clients. What is my role as a therapist? I'm there for my client. Yes, I connect with them, understand the suffering, but I'm not there for myself. I'm not there to share myself so much with them. I'm there to listen to them. I'm there to help them. Now, the liberation feminists that I was telling you about look at all of the contextual variables, and they look like how these contextual variables play a role in relationships. And that has not been explored in the literature. When we look, again, when I was telling you about the surveys and the demographic of the surveys, it makes me even question the epidemiology numbers, because a lot of the surveys were majority white therapists. We didn't have much diversity in the samples. There were questions that were never asked. There was no questions about religion. There was no section about sexual orientation. So, you know, it plays a role in that relationship as well that has not been addressed. Now, what is the relevance for family therapy? Well, according to the two studies that I was able to find in the family therapy field, family therapists feel the same amount of number sexually attracted to their clients, the 86% and 24%, right? So it is an issue for family therapists as well. And also there are instances of ethical complaints to AMFT, and the same way that is for other mental health fields. And there's no guidelines. There's no guidelines to help us understand, and especially for a family therapist, what Senem was telling you a little bit before, is that no systemic view, right? Because as family therapists, we believe in a two-way relationship. There's a lot of research out there, a lot of information there when the client is attracted to you and how you can manage that. But there's not so much when you are attracted to the client. And what is that about? There's no much of a systemic point of view. And how does that look like when you have an entire family in the room? That might be very awkward if you're attracted to one family member, and how about the rest of the family? And also another thing to think about is what happens when you have a couple. Because a couple can get very heated, much heated than you can get with a family. I'm just saying that, so couples get hot hit. So there's some information there. The therapist was saying in the psychology field that it was a good thing when they were attracted to their clients, because they pay more attention to their clients, because they remember their clients' stories more. And I'm thinking, yeah, well, if you have a couple and you pay more attention to one than you're paying attention to the other, you're set for favor there, you know, because couples are always trying to triangulate you. Don't you think I'm right? No, I'm right. You gotta tell him that I'm right. And you can't play that role. You just can't. So I would be very curious also to understand, how does that happen? How do you manage that, right? Nothing to tell me anything about it. And the majority of the articles that have talked about attraction and sexual attractions in clients in the literature and how to manage that or how to be able to talk even to your supervisor about that comes from a psychoanalytic approach. It was about 63.6% of those articles came from a psychoanalytic approach. That's when I did my interview on this topic. So what's some of the gaps? Well, as I said, we don't have any systemic understanding. We have a lot of articles come from the psychoanalytic approach, which is very one-sided. It's more of the therapist attraction to the client, but just the therapeutic process and not the relationship as much. There's a lot of quantitative data. That's how we come up with the profiles and everything. Does anybody here watch Criminal Minds?
I do.
The unsub is a white male in middle age. That's usually, right? How they go, the profiling, right? So it's very profiling. Everything we know about this is very profiling. And that's one of the things that makes me wonder, how is that going to help me, right? Having this profile, okay, great. Now I'm white male, middle-aged. Gosh, should I be worried about this? Like, you know, and how is that going to affect? How is that going to look like if I come to a colleague or if I come to another supervisor to talk about this? You know, how's my supervisor going to look at me and go, I knew you to do that because they're a white man. You know what I mean? Like, it's labeling. So there's not much understanding about it, and there's nothing that considers and talk about the quality of relationship between the therapist and the supervisor. Because as systemic thinkers, when we talk about family therapy, we believe in isomorphism, meaning that whatever happened in that relationship between you and your supervisor is going to get translated to your relationship with your clients. So if I'm coming to my supervisor and I'm saying, I'm kind of embarrassed to tell you, but I'm attracted to my client and don't know what to do and feeling very anxious about it. If my supervisor reacts with anxiety like, oh my God, I don't want to talk about it, become anxious with me, how is that going to affect me when I sit in front of my client that I'm feeling attracted to? Right? It has a direct correlation there. It impacts everything. Everybody in the system is impacted. So that quality of relationship has not been looked at. And I would be very curious to know, what I want to focus more is what is going on in that relationship that between the supervisor and the therapist that makes 54% of the therapists not feeling comfortable talking to their supervisor about this.
I don't know where you're posting it. That's the last one? Okay.
So that will be some of the recommendations. Focus on the supervisor-therapist relationship, what's going on in the relationship that is preventing therapists to go and talk to their supervisor about this. Use a qualitative method to understand the process of interaction and how the therapists go about resolving it, right? Because if I'm feeling isolated and I'm attracted to my client and I don't feel comfortable talking to my supervisor, I have a higher chance of getting involved with my clients than if I have more support. There's a lot of research that says when the prototype, the male, middle-aged, white, whatever, the prototype also says that most of them have experienced the loss of relationship but also feel very much isolated. They're in clinical practice, they don't have supervision, they don't have a lot of people to talk to. So that's where I want to go more with my approach. I want to look at qualitative methods. Yes?
Great. I'd like to open up for questions. I have questions, but I don't know if anything. So what?
Look like he has a question.
All right.
I have a question. You're
Yeah.
like,
Go ahead.
ask, but I'm not sure.
Go ahead.
You have that facial expression.
I'm just curious, like how did you get started on this project? Like, why this question?
Why this
To
question?
you specifically, like.
The therapist attraction?
Yeah.
Okay, because as I said, I like to focus on the things that I struggle with. And I feel like I struggle. I never felt sexually attracted to a client yet, but I'm terrified of feeling that way because when I'm attracted to somebody, I'm like, I'm so goofy. I'm goofy by nature, but I'm even more goofy, you know? And I'm wondering, like, how is that going to look like in session? Am I going to be like, oh, that's wonderful? Or am I going to be like, I can't look at the person, I'm attracted to them. You know what I mean? I'm very expressive. You can see things on my face. So I kind of wonder how it would look like. You know? And I do struggle with families that I feel very attracted to, not in a sexual way, but in a way that, oh, aren't they great? You know, I'm going to miss them so much when they're gone. Like, can we be friends? Can we have like contact with them? And I know it's not appropriate, and I find it hard. I find it very hard to do because I connect with them. You know what I'm saying? So that's why I start kind of like questioning what is my role as a therapist and what I need to be focused on my relationship with my clients. So that's how I came up with that question. That's it.
So you mentioned that it wasn't until the 70s that they came out with the guidelines saying that it's unethical for you to like date patients or 5 years after or whatever. And then you also mentioned that you also mentioned that how the guidelines are in place in terms of when the therapist sees that a patient is overly attracted to them, but there are no guidelines for the therapist. And my question was like, there has been no guidelines whatsoever set by the APA or any other board in terms of the ethical.
Not really. You know, I think it's funny because when we talk about suicide, the APA is very strict. Here are the questions you need to ask. This is everything you need to do to make sure that you have the best interest of your client. Your client doesn't go and commit suicide and you get a lawsuit, right? But for attraction, not really. All they say is that you'll have sex, pretty much in a nutshell, you'll have sex with your client. After a 2-year, APA is 5 year, AMFT is 2 years, but it depends on the state you're practicing, could be up to 7 years. So, but no steps like step by step what to do. You know what I mean? There are some books, Pope, you have seen like a lot of my reference come from Pope. He has written a lot of stuff about this, and he has written a book that talks a little bit from the psychologist perspective of how to look for your supervisor when you're feeling attracted to your client and things like that. And things that, to me, this is such a kind of a new topic, right? Because it didn't get attention until 1977. So who is actually training the supervisors? Because most of the time, supervisors might not know what to do either. To give you an example, in my side right now that I'm doing my internship, you know, I like to talk to people. So I go and I talk to, do you ever feel attracted to your clients? You know, how do you deal with that? I start asking on the side. And one of my colleagues said that she had a sexual dream with her 15-year-old client, and she flipped out. She didn't know what to do. She got very anxious. She was embarrassed. So she decided to talk to her supervisor about it. And her supervisor was like, okay, so let's talk about your other kids. You know, and then I asked her, so what did you do? You know, and how are you going to do this? And she was like, well, I don't have to worry about it because I got another job, so I'm leaving. So I don't have to deal with that family, and I don't have to deal with the boy anymore. But she was like, it's going to be a very difficult last session with him. She was like, I don't know what I'm going to do. You know? So, and then she asked me, like, do you have any suggestions? Like, no, but, you know, maybe you can try a different supervisor or go back to a supervisor. I don't know. So, you know, it's something that I'm very interested in because it's hard. It's very hard to be a therapist. You get attached to people, you know, and it happens.
I'm sorry. You want to go ahead?
I'm just curious, you know, the idea of the qualitative research to understand the process. How difficult do you think it would be to get therapists to be honest about their experiences with this? Because it seems that it would be sort of risking their professional
credibility.
Yeah.
You know, I get that question all the time. And it was about 2011, 2 years ago, I did a presentation with Ken Hardy at AMFT. And we had a room filled with family therapists, professional, right? And we're talking about this. I have 3 people in the audience who actually share their experience of attraction. And some were very risky. You know, one, she said, well, I told my client that I was attracted to him, and I'm sorry I got to terminate you because I can't focus on our sessions because I'm getting distracted, because I'm sexually attracted to you. And everybody was like, oh, okay, you know. So we had people who had volunteered that information there. I'm a talker, so I go around and I ask people, like therapists, like, would you be willing to participate in a study like that? I'm trying to look. And usually when I explain why I'm trying to look at it, I'm not trying to shame anybody, I'm not